Welcome to this session on venous circulation. The reason why we're going to talk about the venous circulation in respects to wounds is that venous malfunction is one of the typical reasons why a patient might develop wounds on lower extremities. This is an overview of the teaching goals. We're going to define a vein and look at the basic physiology of veins. I would like for you to name the major veins, and they also follow the arteries. Understand the importance of venous valve function in terms of circulation, and also understand the pathology in venous reflux and the development of varicose veins. I would like for you to understand how increased venous pressure may cause wounds. Finally, we're going to look at the classification that is now agreed upon internationally in terms of venous disease, and we're going to look at the gold standard for assessment of venous pathology. First of all, veins. By definition, they carry the blood back to the heart and lung circulation from the systemic, so from the rest of the body and back to the heart, and it carries deoxygenated blood. The exception being, of course, the pulmonary veins that return from the lungs to the heart carrying oxygenated blood. The basic anatomy of veins is similar to arteries in that it has three basic parts. It has the inner part, the endothelium, and this differs from arteries by these venous valves that we're going to look into. The middle part is smooth muscle tissue, just like in arteries, but in veins this smooth muscle layer is much thinner and it has no contraction in the same sense that arteries does. So veins are more passive and they are dependent on outer compression from surrounding tissue, especially surrounding skeletal muscles. Finally, you have the adventitial layer, the outer layer, which is a little bit thicker than in arteries. So there's no substantial contraction, and this is important. There's no substantial contraction in the smooth muscle layer of the veins. Veins in general are a low pressure system, and they are dependent on their valves to have efficient circulation of the blood, and we're going to get back to the importance of valves. And the important part of circulation in the veins is that external muscles, skeletal muscles, will create a pump function, so they will exert a pressure on the outside, leading the blood to go in the direction of the heart. So for the veins, I would like for you to think of this slightly differently than arteries. When it comes to the veins, we typically divide this into a deep and superficial system, and the deep system on the left, similar to the arteries in terms of foot veins that drain into posterior tibial vein, anterior tibial vein, and the peroneal or the fibular vein. Together they go together into what's called the popliteal vein, and this continues on, changes its name to the femoral vein, and there's a superficial of the deep veins. There's one called the superficial and one called the deep, but they're both part of the deep system, and they join to become the common femoral vein. And then as it moves towards the heart and it crosses the groin, it changes its name to the external iliac vein, just like the artery going the other way changes its name from the external iliac artery to the common femoral artery. The vein will change its name from the common femoral vein to external iliac vein, and it will join the external iliac vein from the other side together with the internal iliac veins and become the common iliac vein, and those two will join to become the inferior vena cava, or the large collecting vein that enters the heart. If we look at the superficial veins, and they're going to be important when we talk about wounds, there are especially two, and that is the long saphenous vein that is located on the inside of the thigh. It starts down here and it moves, or the blood moves in that direction, collecting small superficial veins into the long saphenous vein. It goes all the way up to the groin area, where it dips into the deep system and empties its blood into the femoral vein. Whereas the short saphenous vein, the little brother of the long, is on the back side of the lower leg, and that empties into the popliteal vein. We're going to take a look at venous pressure, since this is a low pressure system, and the veins are sensitive to the gravitational pull of the Earth's core. What's going to happen is, if you lie flat like this, the pressure within the veins is going to be about the same throughout the body. So the pressure down here by the ankle is going to be somewhat close to 5 to 10 millimeters of mercury, and the same in the head. Whereas if the person stands up, so up to a standing position, what happens is you'll have a gravitational pull that increases the pressure by about 100 millimeters of mercury down by the ankle. So what you'll have is an arterial pressure that is about 100 when you're lying down, because of the active pumping function of the muscle layers and the contraction of the arteries to sustain high pressure. And the capillary bed will have a pressure of about 10, and as we mentioned, the veins about 5 to 10 millimeters of mercury. And as a person stands up, this increases by 100, so you'll have a 200 millimeters of mercury pressure in the artery, 110 in the capillaries, and about 105 to 110 in the vein. And this is a very high pressure for the vein to withstand, because it's a thin walled structure. So what you would want to do is lower the pressure here. As you're standing, what's going to happen is you start walking, and standing, the venous pressure might be around 100, but as you start walking, the muscles in your leg is going to squeeze on the veins, and it's going to push the blood in the direction of the heart due to these valves. And the valves are going to close whenever the person stops, which is going to prevent the blood from falling back down. So that's not going to happen. And as you move along, the leg is going to, the muscles are going to pump the blood towards the heart with the aid of these valves, preventing the blood from falling back down. And as the person continues walking, the venous pressure drops below 30 in the ankle. As soon as the person stops walking, the venous pressure will slowly increase again to about 100 millimeters of mercury. So where are these valves located? Well, it turns out that close to the heart there are virtually no valves at all. So the inferior vena cava and the common iliacs rarely have any valves. Less than 10% of people have valve in the common iliac vein. Around 1/4 has a valve in the external iliac vein, and about 2/3 of us, we have a valve in the common femoral. So in this area right here. In this area, the thigh, we have about 2 or 3 or 4 valves, Whereas below the knee right here, below the knee, the valves are numerous, up to hundreds. Now we're going to look at what happens when these valves are ineffective, or whenever they become leaky. A venous valve that is leaky causes what's called a venous reflux, meaning that the blood will fall back down as soon as it's pushed up. So the muscles, the skeletal muscles on the outside here, will squeeze on the vein. The blood will be pushed up, but the valve doesn't work, so the blood will fall back down. This can be primary, meaning that a person might not have valves that work, or secondary, which is the most common. And one main cause of secondary valve or leaky valves is something called the post-thrombotic syndrome, and we're going to talk about that. So I want you to just understand that leaky venous valves will cause this muscle pump function to fail because the blood will fall back down and the pressure will not be lowered, and eventually this will cause a chronic venous hypertension. So it will cause a chronic increased pressure in the veins of the lower extremity. So before we go on, I'm just going to mention the post-thrombotic syndrome. This is when you have a clot in the vein. It can be any deep vein that has a clot, meaning that the blood will not pass, and the clot here might cause two things permanently. One is it might damage the valve, so the valve itself might be destroyed or leaky. Secondly, once the clot is removed by the body, there might be scar tissue left, and worst case, that can lead to the vein being occluded, which in physiological terms means that you'll have an obstruction. So the blood will try to move towards the heart, but the vein, the deep vein, might be completely occluded. So sometimes the valves are damaged, sometimes you'll have an obstruction, and some patients might have both after suffering a deep venous thrombosis. The post-thrombotic syndrome has a common symptomatic a clinical picture of leg swelling. There might be skin changes, might be ulcer development, and usually pain in the leg. The deep venous thrombosis in itself is an acute event, so the patient might call a doctor or an ambulance and being given anticoagulants. But the post-thrombotic syndrome might occur months or even years after the deep venous thrombosis occurred. So it's important here to have two expressions perfectly clear. One is reflux, meaning that the blood will be pushed up in the vein but fall back down, and this causes increased venous pressure. A chronic increased venous pressure or chronic venous hypertension causes an inflammatory response. It causes irritation in the capillary bed, leaky capillaries, and it triggers the immune system, and this eventually causes wounds when this affects the skin. Second term is obstruction. Obstruction means that the vein, the deep vein, due to the scar tissue is now closed off or really narrow. So the blood is not going to fall down. The blood is still going to move up in the vein if the valves are working, but it's going to be really resistant to blood flow towards the heart. So the patient might feel that the leg is going to swell up whenever he or she is walking, but whenever they're standing or whenever they're in really slow movement, they might not have any chronic hypertension in the leg. at least not to the level that causes wounds. So obstruction in and of itself rarely causes wounds, but the reflux does, and a lot of patients might have obstruction and reflux. But these two terms, reflux and obstruction, are usually used in the term venous insufficiency. You might see the venous insufficiency being mentioned several places, but I want you to differentiate between the reflux and the obstruction. So what happens with a leaky valve or this reflux is you have the chronic venous hypertension, and that increases the pressure down by the ankle, and this causes an inflammation. And this is due to a triggering of the immune system in the capillary bed as the pressure in the veins increases, causing an increased pressure in the capillaries, causing leaky capillaries. And this triggers the immune system surrounding the capillaries, and you have an inflammatory response, and this will cause wounds when it affects the skin. We're going to look at the medical classification or the clinical classification of venous insufficiency. Remember, venous insufficiency encompasses both the reflux and the obstruction, and it's called CEAP. CEAP are simply letters denoting the clinical picture, so what you see when you examine the patient. The origin of the venous insufficiency, is it primary or secondary? The anatomy, which of the veins are affected, are the superficial veins, the deep veins, or the connection between them called perforating veins. And finally, pathophysiology, is this reflux, is it obstruction, is it both? We tend to focus on C, the clinical picture, and this is how we classified from 0 to 6, and 0 being no signs of venous disease at all. C1 is when you have these spider veins or the telangiectasia. C2 is commonly the reason why a patient might go to see a doctor, because they notice these varicose veins, these dilated veins due to leaky valves. Before you have any wound development, you'll have edema due to leaky capillaries. So the capillaries will leak out fluid into the interstitial, and this will cause an edema. And as the inflammatory response continues, you'll have skin changes, which is a C4, and eventually C5 and 6, you'll have a wound or a healed wound. And this is the official setup or the official overview of the CEAP classification, also denoting the E, the A, and the P right here. But as I mentioned, we focus on C, 0 to 6. And this is what the clinical picture of the C will look like. 0 meaning there is absolutely no visible change at all, so we're not going to focus on that. But 1, you'll have these small reticular veins in the skin. This is mostly a cosmetic problem. 2 just means that you have dilated veins, varicose veins, and then there is a reflux, not necessarily causing any problems. Most of these patients will just denote that it's a cosmetic issue. Once it reaches the level of edema, you know you have a leaky capillary bed, and you'll have the start of skin changes. And 4, you have visible skin changes, and 5 and 6, you'll have a wound problem. Finally, I'm just going to mention the examination and the treatment. The gold standard is ultrasound. It's non-invasive, it's quick, and it does not require an extensive amount of training, but you do have to know how to set up the color duplex and how to use an ultrasound. But we tend to train our young doctors within 6 months doing this, and then they can do these examinations by themselves, and you don't have to be a doctor in order to do this. But that's commonly what's the premise in the hospital, is that this is being done by radiologists or vascular surgeons. We have the patient in a standing position, and that way we can mimic the movement. So we'll have a cuff, a pressure cuff around the leg, and we'll squeeze that and push the blood up, and then we'll visualize on the screen if there is a reflux in these veins, and we can check both the superficial and the deep system. The superficial reflux alone can be treated with an occlusion of the vein using heat or glue or similar, and it's the treatment takes less than an hour and it's done in local anesthesia. If the patient has deep vein pathology, we require further testing, might even do invasive testing before we offer any treatment, and we can't just occlude the deep veins because they're too important for the venous circulation. So let's recap. We have defined the veins and the basic physiology. We also looked at the major veins, the lower extremities. They follow the arteries. Just understand that we talk about a deep and a superficial system separate from each other, but they are of course connected in the sense that the superficial veins will empty its blood into the deep veins through perforating veins or through the specific connections that we know from the lesser saphenous vein into the popliteal and the greater saphenous vein into the femoral vein. Also understand the importance of the venous valves, and that's specifically important in both the circulatory function, but also when they leak, we have venous reflux, and that causes the varicose veins. We have talked about increased venous pressure and how this causes wounds, and we looked at the classification, and finally the gold standard of examination, which is ultrasound. And that's it.